Thank you for inviting me to speak about Røysumtunet and our experiences from Europe's first dedicated facility for the severely ill ME patients. I have no disclosures except for that I work as the doctor in charge at the unit. Røysumtunet was first established as a long-term care unit for complicated epilepsy patients. And in 2020, there was established a cooperation between the ME National Association in Norway and Røysumtunet to start a ME unit at the facility. It is a non-profit organization, a decanal organization originally. We have 3 houses. Each has a capacity for 4 patients. An extensive remodeling was necessary to meet the patient's need for reduced inputs of light and sound. The staff consists of registered nurses, a research nurse, healthcare providers, occupational therapist, a physician, which is me. I'm a specialist in internal medicine and infectious diseases, a physical therapist, a psychologist, nutritionist, and Professor Ola Didrik Saugstad, who is the head of the research program. We have a clear biomedical approach. Our care is based on the NICE guidelines for ME/SFS as of 2021. Our core values is a deep respect for the ME person and individualized care. We have also introduced a 4-step treatment program built on recent research results. Our main monitoring tools is the SF36 fatigue scale that is measured at admission and every 3 to 6 months. We are also currently introducing the Fitbit wrist device to register heart rate variability, sleep, respiratory rate, oxygen saturation, steps, and calories. We believe that we have entered into a new area. There are a multitude of studies that come out with positive results, although usually only for some patients and with limited effects. As you all know, there is still no cure for ME. But we believe that it's possible to select good studies and put them together in a program, and we have made this 4-step program and seen amazing results. Some of the studies are randomized and double-blinded, and some are not. Our program utilizes selected vitamins, minerals, and low-dose drugs. I also have to emphasize that it's not formally a research program, nor a clinical trial. It is a search for a new strategy for the treatment and management of a serious disease, where often year after year pass for a large proportion of patients without improvements, as we know. I will go more into detail about the treatment program. The treatment has 4 steps. Each is tried out for 2 months. After 2 months, we evaluate, are there any effects? If there are, we go on and add the next step. If there aren't, we stop it and move on to the next step. So patients can end up by utilizing all 4 steps or none. Our experience is that the average patient benefits from 3 to 4 of the 4 steps. The 4 steps are thiamine and ORS in step 1, NADH in step 2, Q10 and B12. The step 3 is low dose naltrexone, and the 4th step is low dose aripiprazole. I will go more into details. First, thiamine, vitamin B1. It's a very complicated theory behind, and we don't have time to go into details. But it's about restoring the methylation balance in the body. The main study we built on was conducted by Bager and his group in Denmark, Palle Bager. And he found a clear improvement on B1, and also that the patients on placebo got worse. And that was a randomized controlled study. The side effects were only mild and temporary, and it's a water-soluble vitamin, and the excess is excreted through the renal pathway. The dosage is weight-based and varies between 600 milligram and 1800 milligrams. We also add some supporting medication as N-acetylcysteine, B-complex vitamins and multivitamin tablets, and minerals like potassium and magnesium. The next step, the next component of the first step are oral rehydration salt, ORS. The theory is that it expands blood volume and increases brain blood flow. The main study we based this on was conducted by Meadow and his group in New York, in USA. And they found that it improved POTS and cognition. There are few side effects. It's very simple, and it's better than intravenous administration of saline. And some patients find it difficult to drink because of the taste. But except for that, it's very simple and feasible. It should not be given in heart failure. The dosage is 1 liter ORS twice weekly. And it should be consumed within 1 hour to get this boosting effect. In step 2, we have first 2 potent antioxidative drugs. That is NADH and coenzyme 10. It is believed that their antioxidative effect improves mitochondrial dysfunction. The main study we based this on was conducted by Castro Marrero in Spain and his group, and it was also a double-blinded randomized study. They found improvement of both cognition, sleep, and energy. No renal or hepatic negative effects were found. The only thing you should be cautious about is that Q10 increases the effect of warfarin. They shouldn't be combined. The dosage was 200 milligram of Q10 and 20 milligram of NADH. The second component of the second step was B12 hydroxycobalamin injections. It's very complicated to explain everything about the background, but the core is that it is an important coenzyme for methylation reactions. For example, the transformation of homocysteine to methionine. And we based this on a study that was done in Sweden. We're very Scandinavian today. So Björn Regland at Gottfriedkliniken in Sweden, he did studies where he found that they were also double-blinded and controlled, randomized. And he found improvement of cognition, energy, and pain. It was long debated whether high-dose B12 could give cancer, certain kind of cancer. The WHO performed a review and came out with no such association. It's also known that high-dose B12 could reduce the effect of opiates and SSRIs through the CYP3A4 and 2D6. The dosage is 10 milligram, given subcutaneously twice weekly. And we found that the effect increases with higher dose and more frequent dosage. The third step is low-dose naltrexone. The theory is that it increases the level of endorphins and have a pain-killing and immunomodulating effect. The main study we build on is a study of Olli Polo in Finland. And they found that it increases cognition, energy, and reduces pain. That was also a randomized controlled study. The side effects are mild because it's so low doses, but mostly lively dreams. And we also have observed that the patients often get worse before they have improvement, and that the effect can be rather slow. It can be up to 6 months before we see the full effect, but the effect usually occurs within 2 months. The dosage is increased very slowly. It can also be dissolved in water for a very slow start, but we end up usually with 4.5 to 6 milligrams. The fourth step is low-dose aripiprazole, which is also called Abilify. It's a very complicated drug, and but the core in this connection is that it inhibits dopamine transmission overactivity and thus reduces brain inflammation. It is well known now that there is extended brain inflammation in ME patients. The main study we based this on was conducted by Crosby and his group at the Stanford University in USA. It was a pilot study, and as you told yesterday, it is they're applying for means to make a larger scale study, but it's very interesting effect. And I treated in my private practice more than 100 patients, and I see most patients have a positive effect. And also we have seen that at Røysumtunet. So it's a very interesting drug. The side effects are usually mild at these low doses. It's headache, sleeplessness, and anxiety. It was also debated whether it could give weight gain. It's known to give that in full scale doses, but at these low doses, it was found that it at the level of other ME patients. Here we also start very slow with the mixture 0.25 milligrams. The maximum dosage ends up for most patients between 1.25 to 2.5 milligram. So what are our results so far? We found that 8 patients improved from very severe to severe or better nice severity grade. And that was far beyond our expectations, because most of these patients have been bedridden for many years. We also found that 6 improved within the same nice severity grade, which is also great because it's every little improvement for these severely ill patients matters so much. 2 patients were on partial treatment. 1 was unchanged and 1 improved within the same nice severity grade. 3 patients didn't want to receive treatment for different reasons, and they were all unchanged. So what have we learned? The most striking is that among the 8 that improved substantially from very severe to severe, some even reached a moderate or nice severity grade after being in bed in a dark room for years. And we also observed a synergy effect. The more of the 4 steps that was tolerated and successful, the larger the improvement. And the 3 that did not want treatment became a sort of control group, which indicates that good care and maximal energy economizing improves the quality of life, which is also a very important goal of this institution, but it does not improve the energy level. When all this is said, of course, we have to be very careful to draw any kind of conclusion. This is a very small number of patients, and it's a risk of observational biases are clear. What we also found was that public funding was more difficult to obtain than we expected. Many patients want to come to Røysumtunet, but the local municipality or health authorities where they live will not support them. And we also found that to train personnel is time-consuming. These are very complicated and demanding patients, but also very rewarding. We had a high turnover of nurses, and it seems that either you like this or not. But those who stay, they are very dedicated and very good nurses. And we see that they are complex patients, very often with a high degree of comorbidity, both somatic and psychiatric. So, I will end by quoting Albert Einstein. Information is not knowledge. The only source of knowledge is experience. You need experience to gain wisdom. And this has surely been a fact in our journey at Røysumtunet. Thank you very much.
Thank you, Dag. Questions?
Thank you, that was great. I'm here because my partner has severe ME and has been entirely bedbound, so that was really useful. Entirely bedbound for 18 months, non-verbal for most of that time. So it's very difficult for us to get an assessment of what things we're trying are helpful or not helpful and what kind of impact they have, because we don't have that verbal communication with her. What objective or subjective measurements do you see are most useful that you track, or you would advise us tracking to try and get some insight into how effective these things are?
I think it is important that they are observed by different healthcare professionals and over time. And verbal communication is not the only thing that should be measured. But for example, if and how they move in the bed, how the nutrition is, how the observed energy level, are there any improvement? How much basic care do they need? But we are trying to introduce this Fitbit wrist device that will actually give us some more objective inputs about how they are improving or not.